Asante, I'm humbled. On behalf of the team, I'm going to share with you the results of the study that was conducted to assess access, delivery, and use of emergency contraceptives. All right, I believe we all know that unintended pregnancy is a global health concern due to its adverse health, economic, psychological, and social outcomes. So in the efforts to address this concern, emergency contraception methods are critical in prevention of unintended pregnancies, which may occur in the event of unprotected sexual intercourse, contraceptive failure, and rape. We know studies have shown that the contraceptive pills are safe and they can be accessed through over-counter without the need for prescription. We have two forms of emergency contraception methods, pills and intrauterine device. But for the case of Tanzania, majority of people do use the pills. Our study have shown that there is an increasing use of emergency contraceptive pills. In 2019, 1.9% used contraceptive pills, but in 2023, according to Kadinde and his colleague, the number of users increased by 60%. What does that tell us? It might be there is a prevalent misuse or misinformation regarding the emergency contraceptive. But again, the study used that importation data, which may not fully represent the diverse motivation behind the use of emergency contraceptives. So the results of the study that I'm referring to should be, interpreted with cautious. So why did we conduct this assessment? We wanted to determine the use of emergency contraceptives among women of reproductive age in Tanzania. We wanted to assess knowledge, attitude, practice toward the use of emergency contraceptive pills, emergency contraceptive methods. We wanted to assess the access to the emergency contraception information as well as services. We wanted to identify challenges that are associated with the use, access, and delivery of emergency contraceptives. But we also examine the systems and legal and policy environments for delivery of emergency contraceptive pills, as well as for accessing it. So the study was conducted in 6 regions, which were randomly selected from each zone. From each zone, except for Dar es Salaam, we selected 1 council. Dar es Salaam, we selected 3 councils because of its socio-economic diversity. So we had to select 3 councils. A total of 39 wards were also selected from the selected councils. Depending on the size or number of the wards in the councils, up to 7 wards were selected per council. Uh, we also are, so how did we collect data? We collect data through interviews with women of reproductive age, the household survey, but also we interviewed service providers. And service providers here are referred to as doctors, nurses, ADO, any others who are involved in dispensing or prescribing or emergency contraceptives. We conducted desk review of several key documents. We also analyzed data, secondary data from DHS2, pharmacy and family planning units of the Ministry of Health. We also conducted 74 in-depth interviews with key informants, but we also conducted 8 focus group discussions, which were disaggregated by age, sex, and place, geographical location. So what did we find when we conducted the desk review? Knowledge, awareness, and use of emergency contraceptives is low. Why? Majority of the healthcare providers that we interview were not trained on emergency contraceptives. 48 said they were trained on family planning, but only 11% admitted that they have been, the training incorporated the emergency contraceptive topic. Through our review of key documents, we understand there is comprehensive sexuality education being offered at different levels of education, but the curriculum that they use do not, include issues of emergency contraceptives. Policy environment for delivery, access, and use of emergency contraceptives are conducive, but there are some gaps that we have identified. The guideline for prevention of pregnancy recommends that service providers to offer emergency contraception method to non-pregnant, sexually abused female of childbearing age. That is plus because it's a conducive environment for service delivery. But unfortunately, the revised national guideline for family planning outreach services does not include issues of emergency contraceptives. So I understand the document has not yet been approved, but I think this is an opportunity for the Ministry of Health to include the topic in the guideline. But also, the Ministry of Health recommends that emergency to be used once in 3 months, but there's no clear, basis why they recommend that. But also there is conflicting guidelines. The TMDA guidelines does not allow ADO to handle emergency contraceptives. But the national guideline for family planning recommend that ADO should be used, to dispense the emergency contraceptives. So something must be done to rectify Uh, so using data from different sources, DHS2 and farmers units plus the household data, we estimated the consumption rate per year. As you can see, the consumption rate using the household data, the consumption rate was 0.2, or maybe to make it clear to people. In every 10,000 women of reproductive age, 2 people consumed emergency contraceptive pill in any day in that year. Okay? So when we used farmers unit data, 7 women of reproductive age consumed emergency contraceptive pill. This is out of 100,000. It's not out of 10,000. 100,000 consumed emergency contraceptive in any day in that year. Okay. But when we used the DHS2 data, the number went even lower and lower and lower. I will tell you why in the next few slides, why there is these discrepancies between the household data and the DHS2 data. So we tried to disaggregate the consumption rate by council, as you can see from the household data. Masasi and Ubungo had higher consumption rates compared to the other councils. When we disaggregate by age group, you can see that lower consumption were noted for the age for the adolescents, as well as for the older women of reproductive age. Most of the users were around the from 20 to 44 years. Those were the main users of the emergency contraceptive from the household data. Okay. When we disaggregate data from the DHS2, Ilala Council emerged as, had higher consumers of emergency contraceptive pills compared to the other councils. Again, when we disaggregate DHS2 data by age, the trend was similar for that as that of the household survey. So from the household data, we had a question that wanted to determine how frequently women of reproductive age do consume emergency contraceptives. As we can see, the frequency increased with increased time. But we have to note 16% of the women of reproductive age stated that they consume emergency contraceptive pills more than 3 times within 4 to 6 months. So this is, it's against the what Minister of Health recommends to consume once within 3 months. But again, the proportion is not that alarming. So which circumstances had led to the women of reproductive age to use emergency contraceptives? Majority said not using family planning method. And why they did not use irregular family planning methods is because their spouse, partners, or husbands inhibited them from using the regular methods. And that's why they opt for emergency contraceptives. What's happening? Okay. So those are the reasons why they use emergency contraceptive pills. But here I need you to note the main reason is not using regular family planning methods. So where do they access emergency contraceptive pills? 68%, almost 69% of the women of reproductive age who say they have ever used emergency contraceptive pill access the pills through private outlets. That's other farmers, maybe NGO-operated facilities, and only 21% access emergency contraceptives from a public health facility. So here is where I wanted to a little bit expand why we observe the discrepancy in consumption rate when we use household data versus the THS2 data. As you can see, 69% access emergency contraceptives from private outlets, and the data that we use were health facility based, mainly from public health facility, and it's more likely that the estimation is somehow under. There is underestimation somehow because we were not able to capture data from the private outlets. So we also wanted to know was it easier for them to access emergency contraceptive pills? Majority, not majority, slightly over 50% said yes, it was easier for them to access emergency contraceptives, but significantly low proportion of women of reproductive age from Ilala and the Kondoa councils said it was not so easy for them to access emergency contraceptives. I have issues with moving the slides. Okay, yes, next slide, please. Can you move the slide for me? Okay, yes. We also assess knowledge on emergency contraceptives, but what we found, the knowledge is actually limited. 49% of women of reproductive age do not know the indication for emergency contraceptives. Higher proportions of women of reproductive age from Mbeya and Mtwara didn't know the indication for emergency contraceptives. Again, the knowledge on contraceptive pills varied with age, rural, urban residents. Next. Yes, 82% of the women of reproductive age were not aware that you don't need a prescription to get emergency contraceptives. And this was particularly so for women of reproductive age from Mbeya, younger women of reproductive age and students, as well as those with low socioeconomic status. Regarding the appropriate time to use, the knowledge on the appropriate time to use emergency contraception pills, the knowledge was hugely limited. As you can see, 83% didn't know the appropriate time to use the emergency contraceptives. Again, Mbeya, Mwanza had higher proportions of women who didn't know the appropriate time to use emergency contraceptive pills. The knowledge also varied with marital status. Where do they get our source of information? Their main source of information is friends and peer, which they may not be, well equipped with the right information. So where they get their information, they may be wrongly informed on the use of the emergency contraceptives. Next. So there are many codes from qualitative data, but for the sake of time, I've selected some few codes that I will share with you. One of the key informants said not all of who give information are experts. That's linked to the where they get the information. They get their friends, their peers, and they might not be getting the right information. Okay. The other codes is regarding the stigma that adolescents experience, because when they go to the health facility to seek emergency contraceptive services, they've been judged. Yeah, they are judged as promiscuous. Okay. But during the focus group discussion, issue of the costs of emergency contraceptive pills that hinder access came up, as evidenced by the quotation, no money for ECPs, then give birth. But here, what do we deduct from here? They also, some of them think emergency contraceptives is also used for abortion. No money for emergency contraceptive pills, then give birth. So there's no knowledge, low knowledge on the use, but as well, the cost issues might hinder particularly adolescents to access emergency contraceptives. Oh, in one of the group discussions also, we caught our participant who was taking P2 means killing a baby. Again, limited knowledge, thinking that taking emergency contraceptive pills is linked with killing a baby. Moderator, don't count my time because of the technical issue. Okay, sometimes we fail to save the clients due to stock out. This came out in one with few service providers from public health facilities. Not all the facilities had stock out. But again, harsh language to adolescents and young men might, usually hinder the adolescent to access the services from the health facility. Next, please. So what do we conclude from this study? There is conflicting guidelines. One, recommending adult to, provide emergency contraceptive pills, and the other one say no. According to the level of your education, you cannot handle such a drug. Emergency contraceptives not prioritized because the updated version, which is not yet approved, I guess, does not include emergency contraceptive issues. Emergency contraception pills consumption is low, not alarming, as we think. And the main reason for using emergency contraceptives is not using regular family planning methods. But we also have to take note of the 16% of the users who use more than 3 times within 4 to 6 months. Next. Knowledge and awareness on emergency contraceptive is limited among the women of reproductive age, but as well as some of the service providers. If you remember, only 11% are admitted to have been trained on emergency contraceptive. Access to emergency contraceptive is also, somehow limited. Slightly 50%, over 50% say they can access without difficulties. But the other 50%, they say there are some difficulties to access, and the reasons is, cost, sometimes stock out, stigma, providers' attitude, distance, as well as a limited capacity for the service provider to do so. This also contributes to the limited access to emergency contraceptives. So what do we recommend? Please go to the previous slide. To harmonize the regulations, or the document, the SOMANE, to update the family planning guidelines so that it includes issues of emergency contraceptive, but also to promote use of regular family planning methods. That way we might, prevent misuse of emergency contraceptive pills. There is a need to provide family planning education as well as to promote male involvement, because we have seen the reason people use emergency contraceptive pills because they are not on regular family planning methods. Why they are not on regular family planning methods? Because partners do not want them to use regular family planning. So we need to involve men. Next, please. Awareness campaign, not that you have to use emergency contraceptives, no, but to raise correct, to make people understand why and when they should use emergency contraceptive pills. Okay. Or here we also suggest, we recommend inclusion of emergency contraceptive method in the health education. But again, we can also invest into our social and behavioral change interventions to change the attitude of the users as well as service providers, to get that correct attitude towards the use of emergency contraceptive pill as well as the family planning methods. Okay, we recommend subsidies for emergency contraceptive pills so that it can be accessible by all people. Proper documentation is key for proper quantification, because in some of the focus group discussion, in-depth interviews, issues of stockouts came up, as well as having more than they need, so wasting. Okay, so proper quantifications. If you have proper data, you most likely to quantify the amount that is needed by a particular facility. Okay, transformative interventions, that goes in hand with the CBC interventions. So we also need to train our healthcare providers, including adults and community health workers, to have appropriate knowledge that they can disseminate to potential users of emergency contraceptive pills. Next. Yes, there are some limitations with this kind of study that we have presented. So our results also must be interpreted with cautions. Likely we have underestimated the consumption rate. Why? Because we used health facility-based data, and that's why we missed the data from the private outlet. Again, the data that we had from THS2 do not have details of the repeat use. We just have the figure of the repeat use, but we don't know for the frequency. Knowing the frequency might tell us a story. If they repeat within a short time, or they repeat after a year, after a month. Okay. What else? But again, our sample size was small because of the time we had and the resource that were available. We had to go with the small sample size. So another issue is socially desirable responses. It's most likely some of the people might have been shy to say they have used emergency contraceptive pills, yeah, and therefore missed that number. In our analysis, a substantial proportion of people said they don't remember if they have ever used emergency contraceptive pills. They don't remember if they have used emergency contraceptive pills within 12 months. So that indicates maybe there's something they're hiding. Next. I thank you for your attentive listening.
Jamani, makofi kwa presenter wetu. Yes, a big round of applause to Dr. Kijakazi from the National Institute of Medical Research for a well done presentation. I actually considered your time, so I added 15 minutes to your presentation. So we are at a point where we are actually going to the discussions. And for us to do this, and of course, in just a matter of beginning the conversation that we're going to have, I want to take this opportunity to request the organizers to help us actually rearranging the seats properly, and then from there I will be inviting the panelists for this discussion. I will have to, based on the presentation that you've made, Dr. Kijakazi, I would request you to really come and join me on the stage. Makofi kwake tafadhali. Asante, Dr. Kijakazi. As I said before, Dr. Kijakazi Mashoto is a public health specialist and epidemiologist with several years of research experience in health service, operational and implementation research. And she also serves as head of innovation and commercialization and technology transfer at the National Institute for Medical Research, NIMRI. Karibu sana, Doctor, and thank you for your presentation. The next speaker for the panel today is Mr. Machumu Mieye. Machumu Mieye is a committed supply chain specialist in the Division of Reproductive, Maternal and Child Health of the Ministry of Health in the mainland. He has over 80 years of experience in the public sector supply chain and is very passionate about strengthening the national supply chains to ensure availability of essential commodities, RAMCA commodities, at the last mile. And he's also a pharmacist and also holds a master's in science in health supply chain management from the University of Rwanda. Join me in welcoming Mr. Machumu Mieye on the stage. Karibu sana, and thank you for taking time to join us. The third speaker for our panel today is Mr. Patrick Kinemo. Mr. Patrick Kinemo is the country director at Maristops Tanzania with extensive experience in health services across Tanzania, mainland and Zanzibar. He specializes in family planning, reproductive health, and integrated population health. He has a master's graduate from King's College London, and he significantly contributed to the MIHR project for sustainable health outcomes. Karibu sana, Mr. Patrick Kinemo. Help me inviting him. Asante, karibu sana. Yes, taking the shortcut. Asante. I also will be joined by Dr. Kuduishe. She's well known, very active, influencer on social media, digital platforms. And she's a medical doctor and a health communications expert dedicated to advancing maternal and child health. She's a member of WHO Fights Influencers Network. She will tell us more about that. And she advocates for reproductive, maternal, newborn, child, adolescent health and raises awareness about antimicrobial resistance among Tanzanian policymakers through articles and videos in Swahili and English. Actually, tumpigie makofi Dr. Kuduishe. Asante sana. She has a vast knowledge of what is happening in the communities and an active member of social media platforms, which is very key in terms of information to adolescents and young people in Tanzania. And the last speaker, panel speaker for today, our own pharmacist, Suma, David Jairo. She's the head of pharmaceutical policy and practice component at the Ministry of Health, advising on rational medicine use and health technology assessment. With over a decade of experience in the pharmaceutical industry, she specializes in policy creation and healthcare administration. She holds a bachelor in pharmacy and medical masters in science degrees, several universities and colleges. Number 2, mpigie makofi pharmacist Suma akijumuika na sisi hapa katika stage. So this is karibu. This is just to trigger the conversation around the presentations and the findings that we've just heard from our own presenter. And I think I'll just take this opportunity to welcome you to this discussion. And of course, we expect to tap your experiences and knowledge on the issues that have been presented here. And of course, at some point somewhere, we'll also invite the comments and questions from the floor. And hopefully, you'll be able to unpack the topic at hand. So, as I'm actually setting up, because I don't want to really take the questions out of my head, I want to make sure I ask you the questions that will direct you to respond to some of the issues that emerged in the study that was just presented here in front of us. And I'll start with you, Mr. Patrick Kinemo. There's a debate on whether ECPs should be termed or should be over-the-counter drugs, and of course, or not. Looking at the findings of this study and given your experience in other countries and the way that you've been working in the sector, and of course, drawing the learnings, the guidance that we're getting from WHO on emergency contraceptives, is Tanzania on the right track? Are we ahead of time? Are we lagging behind? Where are we as a country, given your experience? Karibu.
Thank you very much, Kimaru. So just maybe to declare an interest, also a pharmacist here. I can see pharmacists are overrepresented. There's 3 of us here. Yes, I've had experience as a pharmacist. I worked as a community pharmacist for 10 years in England. That was 2002 until 2012 or so. Yeah. And at that time, I think that's when the ECP was actually moved from a prescription-only medicine to a pharmacy medicine in England. And so I was involved in the pilot. So in a pilot, I was working in a particular area called Brighton, and it'd probably be the equivalent of a council. So there, again, health is in a way devolved. So the council had to make a decision. So they were faced with the challenge of teenage pregnancies and so on and so forth. So one of the decisions which they made is that they wanted to pilot improved access to emergency contraception. So it was initially only available through a doctor's prescription. So they said, okay, looking at the safety profile, it was seen, and it is safe in general, in the sense that it's equivalent. Its safety profile is the same as the normal emergency contraception. And I can quote WHO on that. So they say, side effects from the use of ECP are similar to those of oral contraceptive pills. And then they mention the minor side effects: nausea, vomiting, slight irregular bleeding, fatigue. Those are the common ones. They also say that drugs used for emergency contraception do not harm future fertility. There's no delay in return to fertility after ECP. So the profile was the same. So to them now is a concern that how do we reduce teen pregnancies, particularly with respect to the ones who have accidents in terms of having sex without contraceptives. So they piloted this through the pharmacies, where they trained all pharmacists on how to use and also on giving advice to clients on all contraceptive methods. So when clients came to the pharmacy, it presented an opportunity for the pharmacists not only to sort of counsel them with their immediate need, but also counsel them, give them comprehensive family planning counseling to other methods. So that was very successful, and later on it was rolled out throughout the country. So remember, this is 2004, and this is 2024. This is 20 years ago. So I would say, if you ask me where we are in Tanzania, I think we're in the right trajectory in terms of where ECP should be. I think it should be at the pharmacy level. I think it should be at the ADO level. If you compare UK and Tanzania, in terms of pharmacies that they have, at the time when I was working, they had almost 12,000 pharmacies. Here in Tanzania, I think there's, I don't know, maybe 400, 500 pharmacies. But if you take ADOs, you get to that number of probably 10,000 plus. So I think the ADOs should be okay. And considering the safety profile that being the same as the oral contraceptives, I would say, for instance, now, community health workers are allowed to give the oral contraceptive pills. So I don't see any reasons why they should not be also allowed to give ECPs per se, so long as they are trained carefully on that. And yeah, thank you.
Thank you, Mr. Patrick. A round of applause to him, and such a very great experience, actually. We appreciate. We'll come back to you later from what you've just said. Now, sorry, I'll go straight to Dr. Kudu. And, you know, we've seen from this study that there's a notable knowledge gap and misconceptions on not only among the users, but also among the health providers in terms of attitude and the way they think about ACPs. And you can see from the study, around 83% of users do not know the right time to use an ECP. And of course, the same percentage are unaware that no prescription is required for ECP's access. And some of the responses that we got from the providers also show, you know, some of the providers were also considering ECPs as a prescribed medicine or drug. And of course, a big majority, like 1/3 of the respondents, said they have heard about an ECP from a peer or a friend. And this is, you know, if the knowledge is limited and if providers are not really informed of how they should be dispensing this kind of drug, then there's a very big challenge in our communities. So, are we confident enough we have the right sources of information on anything family planning, and in particular emergency contraceptives in the country? What can be done?
Okay, thank you, Oscar. We have the right information and right sources of information about emergency contraception, but I think we are not reaching the public enough. Most of the knowledge is, most people say they get from their peers, but we really have to know where did their peers get that knowledge. As the previous presenter said, most people are judgmental when it comes to issues of family planning and contraception at large. And it is one of the topics that is faced by a lot of infodemic, but little is done to curb the infodemic. There's so much misinformation that is being peddled about contraception, especially emergency contraception. And unfortunately, this kind of misinformation is being parroted even by political leaders sometimes. And nothing much is being done to debunk such misinformation. So we have so many sources of information, but the wrong information is being peddled. I think, what can we do? We really have to make use of the channels that we have to tell the public the right information. As Dr. Mashoto said, that we are not encouraging people to use emergency contraception. We are just telling them what is the right information about it in case they need to use emergency contraception. But in regards of overuse and misuse of emergency contraception, we have seen that almost half of them are using emergency contraception because they cannot use regular forms of family planning. So there is a need, if we are to reduce the overuse and misuse of emergency contraception, we need to start by giving proper information about family planning methods so that people will be ready to use long-term family planning methods. And how can we do this? We can collaborate with the media through different channels. We have seen that apart from peers and health workers, the next set of people get their information from radio and TV and from social media. But these sources of radio and TV, most of the time they peddle the same misinformation and disinformation about emergency contraception. Popularly in Tanzania, we talk about P2 every day. So we can use programs that usually target women of reproductive age, such as Jua Kali. I think a lot of women know that and watch that. They can include such information during their sessions or during the ad break. We can be peddling our ads about emergency contraception. But apart from that, we can use mobile health initiatives. Tambua TB is one of the most successful mobile health initiatives that someone can use USSD number to just, and it's free. They can get information from their mobile phone, and they don't even need internet for that. So if we can have something like that for emergency contraception or family planning at large, we will be sure that people are getting the right information. But also we can use, we can partner with pharmacies. We've seen that majority of people get the emergency contraception from the adults and pharmacies. Then we have to train these pharmacists to give the right information that is non-judgmental to the people. People, a lot of young women are not reaching out to public health places for emergency contraception because of judgment issues and the age gap between providers and the young women. A lot of providers in public health facilities are usually older. There's a big age gap. And the younger providers are usually unemployed. So they're sitting there, I'm looking at someone who is the age of my mother, and I'm trying to tell them that I'm 15 and I need emergency contraceptive. So there's a problem there. But just to wind up, I'd really love for Ministry of Health and NIMRI to use social media.
Yeah, Dr. I'm sorry, we are close to the youth event, so we are blessed by entertainment. We should think at some point to embrace it and see how, but I know there's someone who's working on telling them at least to reduce the vibe so that we can keep the conversation. Cindy? Yes, Asante. Please bear with us for that.
Okay, so I really wish the Ministry of Health and NIMRI to embrace the use of social media. Unfortunately, fortunately or unfortunately, most youth use social media as their source of information. So, and when it comes to our government, taasisi nyingi, they don't really embrace social media that much. But I think it's time for them to use social media to provide this kind of education. As you said before, I am part of WHO FIDES network, and this is a network of healthcare influencers from all over the world that are trusted with the information that they give, and we work to debunk the misinformation about different health issues all over the world in different languages. So if Ministry of Health can use us, there are so many healthcare influencers in Tanzania, they can use us to peddle that information. Maybe so many people may not actually visit Ministry of Health pages, but they will visit our pages. Yeah. So we can be used as a way to deliver that message and to bridge the gap that is being seen right now. Thank you.
Thank you so much, Dr. Kudu, and for your offering, actually. Asante sana. You seem to have a very extensive knowledge of how things work in terms of information sharing. Thank you so much. I will come back to you later. And of course, we'll have comments and questions from the audience here. I want to move to you, Suma. I know you're a pharmacist. You are working with the Pharmacy Council, the Ministry of Health. There's one thing that emerged in the findings of this study around the question of unclear guidelines or regulations between the two agencies of the ministry, the ministry itself and also the regulatory authority, which is TMDA. Can you please unpack that? How do we go with that in terms of the clarity?
Okay. Thank you, Oscar. As a policy maker at level of the Ministry of Health, we make policies, but we have our institutions that implement the policy through establishment of the laws, regulations, and then back again to us, we do the guidelines. So we start with the policy, follow with the laws, regulations, and then the guidelines. The guidelines are being developed out of the mentions documents. So at the ministry level, at the policy level, we dedicate ourselves to ensure that medications that are being used by clients, they are of good safety, quality, and efficiency. So when we want to talk about safety, that's where now you see those misinformations, maybe I would say. So TMDA is responsible to ensure the safety, efficacy, and quality. And when we talk about safety, that's where the emergency contraceptives come in. So at the regulatory levels and at the practice level, which is being regulated by pharmacy councils, we ensure that through our regulation, the TMDA medicine schedule regulation of 2015, we schedule the medicine in categories. So emergency contraceptives fall under third schedule. These are pharmacy-only medicine. They've moved from prescription to pharmacy-only medicine. So they have to be issued by a pharmacist at the premise that is well registered and recognized by these authorities. So the emergency contraceptives is at that level. So now clients can go to a pharmacy and be issued such medication. So when we say the pharmacy-only medication is not over the counter, it's that behind the counter. So you have to be assessed. Based on the nature of the medicine itself, the emergency contraceptives, we need to establish safety to a client who is going to use the medicine. That's why it is still on the pharmacy-only category. For that case, we all know that emergency contraceptive has other contraindication, has other adverse effects that need to be established. So the pharmacists, the pharmaceutical personnel that are found in these premises that are being registered by either TMDA, Pharmacy Council, they have personnel who are skilled enough to establish that the client has to be given this emergency contraceptive, has to be educated to provide knowledge on how to use this emergency contraceptive. So for that case, that's why these documents, they need to align themselves. So the review of this document will provide a leeway for them to align themselves, to be harmonized in such a manner that while they are being developed, the safety of a client who is going to use such medication is the first priority. So we needed to provide this EACP in the area where we have skilled personnel and the facility is well equipped. That's why the moment when these this regulation were reviewed, it was 2015, and that's when the guidance was developed. At the same time, we know that ADOS started being implemented in our country 2003. But at that time, there were a limited number of health facilities. There were a limited number of farmers where population would have to go a long mile to reach to get such service. But as of currently, we have almost 12 health facilities where these emergency contraceptives are available, and there are personnel that are available who are skilled to offer such services. As well as we have more than 3,000 pharmacies where pharmacists are available, pharmaceutical technicians who can offer such skilled services and information to the client. So while the recommendation that I'll offer is we align ourselves in these documents that guide the safety of a client first. So our core priority should be safety of the client rather than ensuring just access, because access goes together with right use to the right person at the right time. So all those has to be taken into consideration. It's not a matter of just being offered, but who is offering, with which information, when to reuse it. As it was stated earlier that at what time was concerned on the repetitive use. Those are the key information that clients has to be given, but this can only be given by a person who is very skilled. So we will continue to align ourselves with the documents to ensure that the client safety while using this emergency contraceptive is being the priority. Thank you.
Thank you, Suma. Makofi kwake tafadhali. I'm quite sure there are a lot of questions that will be coming out of whatever is being said here in terms of presentation and also the contribution from my great panelists. Maybe I should come to you, Miyeye, just for a few minutes. I know we'll have time to also allow participants from the audience to really share their opinion. You know, from the findings of this study, we are also seeing majority of users of ECPs are women of reproductive age between 25 and above, 20 plus. And this is against most of the claims that we've had that the adolescents and the young people are actually misusing the emergency contraceptives in the country. And of course, one among the reasons for ECP use is because they do not, most of the respondents say they do not use the regular family planning methods. Is there any hope of enhancing access to and actually utilization of regular contraceptive methods among women of reproductive age? Just briefly.
Okay, thank you so much for your question. In Tanzania, we have a range of family planning methods, from short-term, long-term method, and the permanent method. So for the short-term, we have 3 categories, which are oral contraceptives, condoms, and injectables. And for the case of long-term method, we have the implant and the IUCD. So we have the range of method for family planning. So having the wide range of family planning methods make the client to have the choice based on the, provider counseling at the service delivery point. So we have several options for the client to opt based on the counseling. So having to say that, we have the hope that the client could access the service because of the several intervention or strategies the Ministry of Health in collaboration with the other stakeholders set to ensure that we have the contraceptive security. To start with, the government has strengthened the supply chain system in the country. Starting from 2021, the distribution of waste commodities to the last mile We have reduced it from quarterly distribution to after every 3 months, after every 2 months. So enhancing that has increased the availability of the health commodities at the service delivery point, including the contraceptives. Also, the issue of data visibility. Currently, we have the high visibility of the logistic data. People who can sit at the national level, regional level, even at council level, can have the visibility of the information up to the last mile, like looking at the stock status on a monthly and intervene. Maybe if the facility is having the stock out, can communicate with the nearby facility making the redistribution. So the client can have access of the service and get the utilization of the commodities. The other intervention is with regard to financing. We all know that no commodity, no program. And the issue of finance is very critical in ensuring the commodity security. So the government, in collaboration with the other stakeholders, continues to mobilize the resources to ensure that we fill the pipeline and ensure that the supply plan is well adhered. So in addition, in order to ensure the sustainable use of the domestic resources, the ministry has signed the so-called compact agreement with the UNFPA to ensure that we have the sustainable use of the domestic resources for procurement of the FP and the other reproductive waste commodities. So the other thing, we have other priority like utilizing the postpartum family planning in order to capture women who are going to deliver so that they can also use the methods. So utilizing the PPFP because most of the women who are deliver, they would get advice from the service providers that they can use the family planning for health benefit and spacing. So because we have also integrating these services, they can also be used during the immunization, when they go for the immunization, and the other community and the facility RMSH intervention. So the other thing, we need to address the issues of social norms in order to ensure that the community have the information with regard to the use of the contraceptive method instead of using, the emergency contraceptive. The other thing, we need to ensure that the facility provide the quality services by providing capacity building to the service provider, mentorship, supportive supervision, and providing the right information on the use and the access of the contraceptive methods. So those are the most strategies which is in place by the government to ensure we have the access and the utilization of the contraceptive method, which is the regular method for family planning services. Thank you.
Asante, makofi kwa Miyeye. I'll come back to you, and I think maybe you should know this question, and it might come from the floor as well. You know, we are lacking data, and presenter Dr. Ki, we are lacking data from the private sector. And we know the majority of respondents of this study, and of course, based on the data that we're getting from THS2, it looks like most of the people access this kind of ACPs through the private sector. Do we have systems to capture that? What can be done around that particular area? And I think some of you can also respond. Let me turn to you guys. Thank you so much for listening and following up. And I would like to really take the mic to the floor and invite you to contribute. If you have a comment, if you have a question, you can raise up your hand and then ask. We have the presenter, the main presenter, and also the panelists who can also help us to unpack any questions that you have. I think I've seen the hand from the lady there. And then I'll three. We also take the second, the third. Okay, let's do this side and then we'll go the other side. Karibu.
Hello.
Just 1 minute will be fine because we have limited time.
All right. My name is Miriam Kahabi. I would like to ask...
Sorry, can you repeat the name?
I'm Miriam Kahabi, a peer educator.
Yeah.
Yeah, I would like to ask, I guess, a pharmacist, what strategies do you have to help these adolescents and young women who are misusing the contraceptives, especially the use of P2? We have seen a lot of adolescents are using P2 in a misuse way. And apart from that, I would like to comment if there is anything concerning issue about helping or supportive supervision or provision of information to adolescents or young adults. I guess we should use something so-called edutainments in social medias, because we adolescents do not love reading. Hatupendi kusoma, hatupendi kusikiliza, especially kwa watu wazima. Kwa kama tutakuja na mbinu tofauti ya something like edutainments, something like games, something like music, ambavyo vitu tunavipenda, it will be so much helpful to help sisi vijana. Asante.
Thank you, Miriam. I think they've not taken note of the question. Can you take the mic? No, hapo jirani, Gerard, and then mama hapa mbele. Karibu.
Asante sana. Asante sana. My name is Gerard Kiwele, working with the Ministry of Health, the National Coordinator for Adolescent Health and Gender. On my short presentation on the challenges, there is something conflicting guidelines. I don't know whether Chumu or
Suma.
Suma will at least tell us how. Then I saw Ilala happens to be a highly user of ECP, while with another slight proportion of women of reproductive health, reporting either access to ECP. I don't know whether either access, Ilala found to be the lowest. So I feel like there is a contradicting information here. Maybe Mashoto will help us.
Thank you. Asante, Gerard. Dr. Mashoto, you got it. Okay, mama hapa, and then we'll come at the middle here, watu watatu, and then...
Good morning, everyone.
Good morning.
My name is Lea Bategereza, research scientist from Ifakara.
Sorry, I don't think the mics are working properly. Maybe you should use mine, or maybe put it a little bit closer.
Good morning, everyone. My name is Lea Bategereza, research scientist from Ifakara Health Institute. Thank you so much, Dr. for this presentation. I have a few questions that I need clarification. First of all, I wanted to know if by the time you did the interview made to the pharmacist, were you able to explore the information that they deliver to the clients they come to seek the ESP? And the other thing I want to know, are there side effects of using the ECP more than once when a person has unproductive sex?
Thank you.
Are there side effects of using P2 more than once in a month if somebody has unprotected sex?
Okay, I think some of these questions can also be responded from the ground. So we will be looking ahead at hearing your experiences. Tuanze na Dr. Moke, and then we'll get back to the three of you four, and then see how we wind up. Karibu.
Yep. Mine is more or less kudos to Dr. Kijakazi. Thank you so much for this good study and the good finding. Just a few comments. I noted you had some issues highlighted, especially on the pattern of use, private versus public. I would think that you should be comfortable with the results. They meet even the THS results, the source of these emergency contraceptives. So much as you may be worried that your sample size might have been slightly, I don't know, because you did not provide the confidence intervals. I think, your results can be extrapolated to other existing results. I am sure the THS has a bigger sample size, so I can confidently believe in the results. And you also highlighted on the disability bias, people telling you what they want you to hear. If this is the case, in fact, I would expect the opposite of what you found. So that is unlikely in your case. And again, we need to take evidence positively. When evidence comes on our way, we should take it and use it in a proper way. And it's saddening. I am over 50. It's saddening at times, even the people we call peer educators and whatever, possibly though these are faults from the system, they don't seem to be as well informed as the people they give information to, which is disheartening really, and especially for the young people. All this information is online. You can just go and Google and get all this information, including side effects of repeated use of these emergency contraceptives. They are so myths. Utapata cancer, a lot of things. Evidence is there. You will see and understand such side effects. And in fact, other than possibly irregular menstruation, there is no any other medically documented serious side effect of these emergency contraceptives. And again, going to Suma, if I can even speak in Swahili. Unajua, shida tulionayo ni kwamba we were once young people. And when we grow up, we think haya wanayofanya hawa, sisi hatukuyafanya. We did everything more or less they are doing, including having unprotected sex and everything. But we are in cocoon sort of thinking that our children won't be doing it. They are doing it, and they continue doing it. That's human. And we have seen discrepancies. What the policies describe, even within the same ministry. You say this, and another one says this. Or use it at least once in 3 months, which is not supported. It's not supported with any evidence. If they realize it and they change it, I would expect that the other authorities within the same ministry should also align. We are still embedded into old evidence to inform our young people, which is, I should say, unfortunate. Asante Nelson.
Asante, Dr. Moke. So we have Brother Pale, and then we have a sister, and then two from this side. Unfortunately, we don't have time, but I'll take at least 2 hands or 3 from this side as well. Karibu.
Good afternoon, everyone.
Good morning.
Good morning. Thank you for this wonderful panel. I think I learned a lot from Mashoto, and everything in pamphlet is gold to me. I'm also a disclaimer, I'm a pharmacist, but also supply chain advisor and innovator. We have a booth, it's called Afya Intelligence. We innovate around strengthening supply chains for public sector, which we are working with the ministry, and we are strengthening the availability, including RMSH products. The area that is concerning for, and also it came out, is the private sector, where there is a lack of visibility in terms of what is happening, but also the digital systems that are currently being used were not built to that accountability mechanism that can really allow the ministry, for instance, or partners like Marriott Stops to be able to monitor subsidized products in terms of like pricing or usage or the usage patterns. So I am looking forward. We have something that we are calling Dukadawa, which we are calling it the future of pharmacy. We think with this digital era, we don't need to have, if we have 3,000 pharmacies, we don't necessarily need to build to make it them 10,000. with digital solutions, you can leverage as much as possible. For instance, somewhere like Ilala, I am sure there are a lot of pharmacies which need requirements that Uma mentioned to be able to, for instance, distribute the emergency contraceptives in the best way. So what I would say, I think what is missing is a group of ecosystem players who understand it like you guys, who can help us as we build that future together so that we can try and address the issues around availability, access, use the same platform for disseminating some of the information when people are getting this, but also making sure that it's meeting all the accountability, but also providing the ministry the feedback they need when they are focusing. Because currently they are focusing for the public sector, not knowing what is happening in the private sector. The emergency contraceptive numbers have doubled. The quantities that have been ordered 2 years ago, and this year is more than doubled. So that's an area where we need to work on. Thank you.
Asante, yeah, let's limit our questions or comments in 1 minute, and then we'll have more people speaking. So I want to go through the rest, and then we'll finish. Karibu, for a minute, please.
Good morning.
Good morning.
My name is Krista Frank. I'm a medical student from KSMC, and my question is to Dr. Kijakazi, that in your presentation you said that the annual emergency contraceptive consumption among youth is low, almost 0.24. As NIMRI or Maria Stopes, which kind of initiatives or strategies are you using to champion the use of emergency contraceptives among youth in light of negative attitudes which youth have in seeking the emergency contraceptive services?
Yeah, thank you. I think Patrick will respond to that question. I don't think we are promoting the use of, but again, the regular. Yes, Karibu. At the front and then at the back. Just 1 minute, please. It will be.
Thank you. My name is Michael Tindo. First, I would like to acknowledge my question was during the presentation, I saw something like Lungwe with the issue of easy access of emergency contraceptive. Lungwe was one of the councils that was leading, so I was eager to know whether did we go further to understand the significant difference between the town councils versus the rural councils, and did we go further to observe on the education level about the access of emergency contraceptive? And the last one, we have something known as comprehensive sexuality education programs, which are being held in schools. Do those curriculum allow us to talk the issue of family planning or at large or emergency contraceptive? Na mwisho kabisa nitaka nielezee kuhusu Dr. Kudu ameelezea utilizing social media kama source of information kwenye issues za emergency contraceptive na family planning at large. Nikawa nafikiria kuna wakati fulani issue ya kutumia bamia zilikuwa zinasambaa mtandaoni, like kuna slippery something like that one. Kwa sababu sasa who is monitoring those information? Kwa sababu social media na zenyewe zinachangia pia misinformation. Sasa who is responsible to monitor those misinformation on social media? Thank you.
Asante. Hapo nyuma.
Sorry, moderator. Maybe we can give a 5 solid grace period.
Yeah, it's fine. It's fine.
I think I could advise if the panel could respond, then we can wind up.
Yes, I understand. Thank you so much for the guidance. I know most of the questions are actually having responses, so this will be mostly the conclusive remarks. I want to hear the audience more. Karibu hapa, alafu huku kuna unani? Moja na wapili. Watatu utanivuia radhi. Just 1 minute, please.
Okay. Naomba nizungumze kwa Kiswahili zaidi.
Karibu.
Kwa majina naitwa Machumani Kiwanga, ni daktari kutoka Chuo Kikuu cha Dar es Salaam, ni mdau wa vijana, pia mwanafunzi wa PhD katika medical tourism. My interest nikianzia na research pale, kama ni sehemu ya ushauri pia. Uligusia kwamba WHO na discourage ado kutoa contraceptives. Lakini tukirudi katika utalii tiba, changamoto moja hapo ambayo inatokea ni sababu ya watu kwa nini wanatoka nchi moja kwenda nchi nyingine kutafuta huduma, na swala la contraceptives katika hilo eneo ni muhimu sana kwa nchi yetu kutoa huduma katika ngazi ambayo hata mwananchi wa jirani ya nchi au mkoa mwingine akafika kuipata. Kwa sababu watu wizara hapo hapa naendelea kuencourage kwamba tuendelee kutoa huduma mpaka katika mtu wa chini kabisa. Na eneo la pili, dakika moja. Eneo la pili ilikuwa ni katika sehemu ya research kama iligusa faith leaders na traditional healers, kwa sababu kuna issue ya matumizi ya family planning kutoka maeneo. Faith leaders wana discourage, lakini traditional healers kuna vitu vinaita vigunzi vinavyotumika kwa vijana na vitu kama hivyo. Je, research imefika katika hayo maeneo? Nashukuru sana.
Asante. Haya, tuende kwa mtaalamu hapa mbele dakika moja, alafu tumalizie pale nyuma. Wengine mtanuia radhi. I'm sorry.
Naitwa Frederick Msigala. Swali langu lilikuwa moja tu kwa Dr. Kijakazi. Katika utafiti wenu mligusa watu wenye ulemavu na matokeo yake yalikuwaje, na ulemavu unahusiana vipi na hayo matokeo yake in case mligusa? Maana ni eneo ambalo limekuwa likisahaulika sana. Asante.
Asante Msigala. Tunashukuru. Basi pale mwisho dakika moja. Muda watanizuia hawa. Dakika moja. Is it a burning issue ama tunaweza tukaisamee, tuwape nafasi yao kusema?
Tuna dakika moja ya kufinalize.
Haya. Basi mtanuia radhi, tutakuwa na discussion baada ya hapo. Karibu. Nafikiri tumalizie kwa Dr. Kijakazi, lakini wengine mtatoa remarks zenu based on comments ambazo zimeletwa, lakini Dr. Kijakazi atakuwa wa mwisho kwa ajili ya kujibu yale yanayohusu research zaidi. Tuanze kwa Kudu, kuja huko.
Okay. Nadhani katika
dakika moja itakuwa sawa.
Okay. So issue imekuwa raised kwamba nani ana monitor misinformation in social media. Wizara ya Afya ina kitengo kinaitwa elimu ya afya kwa umma, ambayo ndio mainly ina provide elimu ya afya kwa umma, health education to the public. But I think there's a need for them to be more active ile ku discourage na ku debunk zile misinformation. Lakini as a conclusion, I really wish that tunavyofanya research kama hizi ziwe disseminated to the public. We usually have these discussions scientists kwa scientists, and the public doesn't have these findings hawapati. Kwa hiyo I really wish we use these traditional media and social media kufikisha hizi conclusions na findings, because most of the time ukiwa una debunk misinformation, in my experience, you put an article, usually ni an English article, and people say that applies to white people, sio sisi. Wakati NIMRI has done so many research, they can work with us tuwe tuna disseminate to the public ili tuwe na evidence to tell the public. Thank you.
Asante Dr. Suma. 1 minute.
For my question was on the
Can you put the mic close?
Alignment of the guidelines. Actually, the guideline for the national guideline for family planning 2015, that was the one that recommended that emergency contraceptives to be dispensed at adults level. Recommended. So now, based on other now the higher documents such as regulations said they're supposed to be only issued at the pharmacy level, not at the adult level. As we all know that adult were introduced to only provide a first aid assistance to some few conditions. So now as we are going to review this document, and this document have been already reviewed, then the National Guideline for Family Planning, we're expecting it to be signed. So once we continue with the review of that document, we will align with these upcoming information that we are getting on how to ensure now the accessibility of such medicine to the population. But taking into consideration that back in then when the guideline was being put in place in 2015, we had very limited number of health facilities. Now we have almost 12 health facilities where clients can go to get this emergency contraceptive, and they have even 72 hours, almost 3 days, to access the health facilities to get the oral contraceptives. I know that the major concern here is at the health facility, maybe the procedure is too long.
Exactly.
While at the pharmacy, the procedure is too short. Even at the ADO, people think it's easier, even more shorter. But when we talk about the distance of the health facility to a population, now it's only 5 kilometers. So a client can just go and access this to a very skilled personnel and health facility that is well equipped. We should remember that these emergency contraceptives, they have side effects. Once you want to issue the contraceptive, even the general, the routine ones, you need to establish the health status of a client. You just don't use, if you are hypertensive, and now we know that non-communicable disease is at the top. Even younger generation have non-communicable disease. It's contradicting with those with hypertensive. So all these issues we have to be established. We shouldn't just consider our children are young, but these young children have non-communicable disease, the hypertensive ones. So we should consider that these emergency contraceptives as well have other contraindicative conditions such as thrombolysis. So if they not been taken at a person who can offer this skilled information, I think it will be not in a very safe position. But they will review the regulations with the guideline to make sure that accessibility is easy.
I think the study findings zimetokea at the right time, so it's an opportunity to be included in the guidelines. 1 minute, Patrick.
Asante. I must say I agree with the recommendations of the guidelines that they should be offered even at a lower level. I agree with that. At the facility levels, we have a challenge in terms of HRH. So you might find a lot of facilities there's only one provider or two providers. So they might be challenged to provide contraceptives per se. They might focus on other services. So that might be a barrier to access to services. So having it at ADO level, I think is good. So I think there's an opportunity nowadays, for instance, CPD, continuing professional development is mandatory, say for pharmacists, nurses, doctors, I think technicians as well. So I think health workers can be trained on this, on how to issue it safely, on how to check on those provisions whereby they need to see if someone has hypertension or so and so on. But I think even community health workers can be trained. So I think it should be rolled down. I think the government should consider also actually, as our researcher said, perhaps subsidizing, even at the pharmacy or ADO level. Take it like the way we do immunization. In some cases, government has contracts with some of the facilities. We should have contracts with pharmacies, with ADOs. Perhaps it should be included in the insurance benefit package as well, so that we can actually increase access to people who need it. Asante sana.
Asante, Patrick. Maybe I think you should touch on the public-private partnership and the data. We seem to rely mostly on the importation data than the routine use of ECPs. What is there for that?
Okay, thank you. I think for now, the collaboration between the public and the private is very close, and we are very much working with the private sector. If even at national level we have this commodity security, whereby we also invite private sector actors to participate in this meeting and share their experiences, what is happening there. So the issue of linkage of data, currently we have the organization called Maisha Med, where they are more working in the private sectors, including the community farmers. So we are working together to ensure that we are integrating the system, so that the government system and the private sector, where the information will be integrating each other, so that you can also have the access data from private sector, so that you can have the whole picture of what is happening there. So maybe just one issue to clarify with regard to the one of the area where it looked like it was not very much clear on the ilikuwa ni kuhusu using emergency contraceptive once in a 3 months. Nafikiri hiyo kwa mujibu wa miongozo ya wizara hamna sehemu ambayo imeguide au imeonyesha kwamba hiyo emergency contraceptive iweze kutumika mara moja ndani ya miezi mitatu. Nafikiri ni hearsays naweza nikasema, kwa sababu tunajua kuna miongozo na kama dawa yenyewe inaitwa emergency contraceptive. Kwa hiyo sisi kama wizara tuna encourage client watumie regular method zaidi katika kama matumizi ya uzazi wa mpango. Asante.
Asante, Dr. In a minute, please.
Asante for the question that have been raised about the discrepancy on access. While some people from women of reproductive age from Ilala say they do not have easy access to emergency contraceptives, but also I presented that the higher proportion do use emergency contraceptive. Just to remember, we had triangulated information from different sources. Yes, using our DHS2 data, we saw that Ilala had higher use than other councils, but when we asked the women of reproductive age, they said that they have difficult to access emergency contraceptive. What does that tell us? If you remember what I said towards my conclusions, might be there is some underestimation because of some of the information that have been hidden from us. Or maybe when they respond to the question, their thinking was getting the drug, the emergency contraceptives from health facilities, and they did not consider private outlets. Okay. Side effects when you frequently use emergency contraceptive pills. One of the audience there did highlight that there is no evidence so far that point to the major side effects. But from the literature, frequent use lead to reduction of effectiveness of the pill. So you might think you are protected while you are not, because you have been using it so frequently to the extent that their effectiveness is reduced. So you actually put yourself at higher risk of getting the pregnancy because of frequent use. That's why the issue here should be promoting regular family planning. Thank you.
Asante. Jamani, makofi ya ziada kwa presenters wangu.